Hi, everyone. My name is Lane Dilla. I'm one of the SAM Research Committee members, and it's my pleasure today to host this SAM Research Learning Series on tips for an optimal systematic review and meta-analysis. Our panelists today are Joshua Davis, Nicholas Harris, and Sanjal Lee. I'm going to do a brief introduction, and then we're going to let them kind of take it through some questions that I have prepared for them. But at any point, please jump in and feel free to ask questions as they come up. And then at the end, of course, we'll have a few minutes to also address questions, but feel free to interrupt as we're going through things. So Joshua Davis is an emergency physician in Wichita, Kansas. He is teaching clinically as a clinical instructor at the University of Kansas School of Medicine and as adjunct faculty at the Kansas College of Osteopathic Medicine. He's an assistant medical director for ultrasound quality and research with Vituity in Kansas as well. He completed his residency at Penn State Milton S. Hershey Medical Center, completed medical school at Thomas Jefferson University, and his research interests are primarily focused on emergency medicine clinical topics, including patient safety, handoff communication, diet, exercise. So he has a wide variety of topics of interest and a wealth of knowledge for us today. Our second panelist is Dr. Nicholas Harrison. He works clinically at the IUH Methodist Hospital. As a medical student at Michigan State, he spent 2 months living in Peru, completing the school's MD Leadership in Medicine for Underserved Certificate Program. He completed his residency training at Oakland University, William Beaumont School of Medicine and William Beaumont Hospital Emergency Medicine Program. He followed this up with a fellowship in clinical research at Wayne State University and clinical research design and statistical analysis MSc program at the University of Michigan. In addition to his current clinical work, he continues his translational and health services research in acute heart failure and non-invasive cardiovascular imaging. This is currently being supported by a KL2 Career Development Award funded by the NIH NCATS through the Indiana Clinical Translational Science Institute. And Dr. Sanjal Lee is a clinical associate professor in emergency medicine at the University of Iowa, Carver College of Medicine. He is a clinical scientist with a focus on emergency medicine research, and his work primarily involves delirium screening and intervention programs within the emergency department. He has published over 25 peer reviews on delirium alone, and many of these are systematic reviews. So we're excited to have his expertise as well. And so with that, I'm going to actually stop sharing my screen and jump right into some rapid fire questions for everyone. So my first thing for each of you would be to ask you to take us through your initial steps in kind of planning a systematic review and meta-analysis. What are the things that you think about before you even start the literature search? And I'll let Dr. Lee take it away first.
Sure. So thank you so much for inviting me to be a part of the panel here. A lot of times we actually come across the research questions. So that could be a topic that is considered at the stage of the important equipoise. So there's a topic that your local experts cannot agree on regarding the evaluation or the treatment of certain conditions. So that's a really good place to start. Then you can actually frame the question using a PICO format. So the patient population, intervention, comparison, and outcome. So that's applicable to any of the research questions that we actually have. You do use some search engines. It could be PubMed or Google, anything that you actually have access to a study and literature review. You actually come across a few studies that look relatively similar. And if you think that the studies is actually worth pursuing, then you can actually form a team. So that team actually consists of a principal investigator, that could be you, 1 to 3 abstract and full manuscript reviewers, and a librarian with adequate expertise. The librarian is a key component, and we'll get to that later too, but that librarian needs to be able to create a search strategy. So that's actually one of the key person in the group. The study team will actually need to prepare the study protocol. Once you have a study protocol, you can actually ask librarian to conduct the search and generate a list of articles. You actually start with the title and abstract review, followed by full manuscript review. If you're able, you can actually proceed to the risk of bias, synthesize evidence based on the selected studies, and then you'll actually have a entire picture of the systematic review. And then, becomes a question of whether you can actually do meta-analysis or not. So that's the sequence of how I actually conduct a systematic review.
That's awesome. That's a great overview of the process. Dr. Harrison, would you kind of tell us kind of what your initial thought process is? Does it really surround, do you focus on something of disagreement, or how do you come up with these questions and really define the questions to start with?
Yeah, thanks for having me on the panel as well. I think, Sanjil hit it on the head. A lot of great details there. What I would add to what he said, I think, is as I've done more and more systematic reviews and meta-analyses, it certainly is true that the question and making sure you have the right question is priority 1, 2, and 3. The other thing is, with more experience, I've learned to sort of think a couple steps ahead in terms of, okay, in the very specific wording of how I have this question, is there going to be unintended consequences down the road? And that might be, for someone who's doing their very first systematic review, that might be, a little more in depth, but I do think that that's a helpful skill to consider as you're getting more into the systematic review process and you're publishing more, because little changes in wording in your question and your lit search, they can make a huge difference. Just to give a concrete example, it's not technically a systematic review, but one of the things that I've done for years now is work for the ASAP Clinical Policies Committee. And I will tell you that those questions and the recommendations, if you've ever been unhappy with any of them, just know that I've never imagined that one sentence could ever be discussed for 60 to 80 minutes of wording, but that's really how it is. And frankly, that's what it takes. So being really careful about, the question and thinking ahead a little bit.
Yeah, I think that's a good point. I know from personal experience that took me a lot longer to figure out than I anticipated. I thought it was a very simple task and very wrong. Dr. Davis, would you kind of walk us through any other additional top thoughts when you're designing and really thinking through that initial steps in the systematic review?
Sure, yeah. So, I do want to emphasize, this is a team effort. This is not something you're going to be able to do on your own. One of the benefits of doing a systematic review is it doesn't take a lot of funding, but it's not something that is a single person effort or something that's going to be an easy publication. It takes a lot of time and effort to do one of these really well. And then, like Dr. Harrison said, the planning and thought and taking your time is so important. Having done many of these and learned by experience, when you get halfway through it and then you realize that you need to change your question and start all over again, it's just so frustrating to put so much time and effort into doing something and then just realize, like you said, a one-word change or something you didn't consider, some side factor or confounding variable or something that you kind of didn't think about. So involving people early when you make your team and getting a content expert and some kind of mentor of kind of systematic review. So content of whatever kind of topic you're studying, somebody who has a lot of experience in it and can at least help think through those things for you. And then in addition, somebody who has some systematic review kind of mentorship for you, somebody who's done several of them before can kind of help you. And then as far as kind of topics, I do like Dr. Lee's point of where is there kind of equipoise and what's your experience and things that people can't agree on. Two other areas that I like to do. So I like to do topics that I have an interest in, right? So that it's always more fun to do one that you like than something that is an equipoise, but you find really boring. The other one I like to do is I like to ask why we do a lot of the stuff that we do that because a lot of stuff in emergency medicine actually doesn't have evidence and is done for the reason of because we've always done it that way. And I think those are some of the most dangerous words in medicine. So it's really interesting for me to write systematic reviews on things that I just don't understand why we do it. So if you think about, and these are some examples, some of which I've done and some of which I've kind of thought about doing, but if you look about heparin in NSTEMI, that's one thing. If you try and go find the evidence on that, it doesn't exist. It's actually, that probably shows that it does harm. And it's something that we all do all the time and probably wouldn't even bat an eye at. So all of these little simple things that we do, I think are, you can look at doses of medications or why we do one medication versus another, or, those type things. And I really like to do those and kind of understand kind of what we're doing and what the evidence is behind it too.
I think that's a great point. I'm curious, Dr. Lee, kind of going back to you, when you're thinking about these questions, both Dr. Harrison and Dr. Davis really pointed out of the need to really define that question appropriately so that you kind of save yourself trouble down the road. I'm curious, and this applies to all three of you, that to me sounds like a huge challenge. What resources, I mean, besides having a content expert, which would be lovely in every situation we could possibly have, what other things do you think about when you're kind of determining that scope of the question to make sure that you have enough articles that you can actually combine and review, but aren't just overwhelmed? Because I've seen it go both ways with systematic reviews. Sometimes you'll have a question, you'll have no articles, or one or two articles that actually end up coming up for your systematic review, and others you have thousands and thousands, and you can't, there's no way for you to get through it. So how do you address that, and how do you get your question just right?
So I can actually start, and I'm sure that two of my colleagues here would actually have their own perspective. But yeah, I think if we're going to refine research questions, so using a PICO format, it needs to be refined using a few rounds. So it could be just reviewed by you, or it could be just reviewed by your colleagues. If you have a study team with someone who serves as a mentorship role, I think that person should take a look at it too. And then, a lot of the systematic reviews that we conducted in the past actually needed a few rounds to get to the question that everyone actually likes. So that's the sort of a indirect way of saying that it takes time and effort. I don't think there's a good shortcut around it. If you happen to know the context of that research question, I think that will be an advantage, because you probably have an idea of how many studies or articles actually addressing that particular questions. If you have like two of them based on your like a Google search, I think you're in a really good place, because in order for someone to conduct systematic review and report a finding, you want to have more than two studies. If you have only one study, you're probably not going to get too far. And if you have no studies, then there's a problem. Yeah. So I think that's probably how I would actually approach some groundwork. Say, if you actually have too many articles, that's actually great, but you're also stuck with another extreme situation. So if you say get more than like a 30 studies, that would probably remain in the end. That actually means that you're probably gonna have to restrict your inclusion and exclusion criteria, so you can actually do a reasonable systematic review.
Yeah, Dr. Davis or Dr. Harrison, do you guys have other thoughts on like the kind of, where do you start with that, the number of articles, besides doing this iterative process? Any other thoughts?
Yeah, I mean, I think I don't think there's any one golden number for what's too many articles or what's not enough, but I think it's something that you can sense, if you're getting to 300 articles after, the abstract review stage or the full text review stage, you probably have too many articles. But it depends on the topic. It depends on what you're going for. I would say, to add to what Dr. Lee said, is that when I think that a good way to right size your question is, just like he was saying, you need to do it in multiple rounds. And I think that the context of that, for every systematic review, ideally, you want to have a protocol for, very strictly, inclusion criteria, exclusion criteria. These are the subgroup analyses we're going to do. We will consider this to mean this. We will consider this to mean this. And then you want to register that protocol. And there's lots of reasons, or there's multiple reasons to have a protocol for systematic review. One is so that people can be held accountable and for doing the work they've set out for and registering it. But I think as much of a benefit that may not be necessarily as clear is that when you're writing out that protocol, and then specifically working with your librarian and your team members to pilot some searches and see like, oh, okay, based on what we have right now, we did a pilot search strategy, returned like 10,000 articles because we didn't realize that the way we did inclusion exclusion completely, excluded this thing that should be in there, or included all of these things that should not, that are beyond the scope of what we were really trying to ask. And then that's when you go back to the question and you rephrase it in a way that you can, that you can narrow it, or like I said, right size it to the scope of really what you and the rest of the team think is the key thing that you're trying to distill down to with the literature that you're returning.
Yeah, Dr. Davis, any additional thoughts on that?
Yeah, I think the other thing is kind of specificity that sometimes I see gets lost. So it's very easy to be like, what are the outcomes associated with, XYZ intervention? And like you have to get really specific about like what outcome are you talking about? And also like so going after the PICO model, like what population, like adults, are you going to include children? Are you going to include people? Like, is it a certain like presentation, like the complaint? Is that how you're going to how you're going to define whatever disease process? So some of our disease processes don't have clear definitions. So for example, one of the ones that's coming up a lot recently, I don't know why I'm on the chest pain kick, but like the occlusive myocardial infarction, right? And so like there are actually like you have to decide what your definition of that's going to be there's tissue changes and is this power, does it have to do or does it have to do with the TIMI flow and how do you define that is actually important in what your kind of outcomes and kind of population are? And are you only going to, for example, if you were looking at, what's the accuracy of high sensitivity troponin, like what are you going to look at, patients just with chest pain, or, are you going to count patients who have syncope or palpitations, or, is it in adults? Is it in children? When you're looking at the sensitivity, are you going to define it as sensitivity for occlusive myocardial infarction, for coronary disease, for 30-day adverse cardiac events? Like what outcomes and what? So I think the specificity is important. The other thing is to make sure that you have a question that's worth answering via a systematic review. So I know when we look at the evidence pyramid, you see like the meta-analysis at the top, but the meta-analysis that's of multiple well-done randomized trials is when meta-analysis reaches the top of the evidence period. If you've had one large well-done randomized trial that answered the question already, adding a meta-analysis to add a bunch of little randomized trials that were done before that, a bunch of 50-patient randomized trials, and you have this 2,000 patient study, that your weighting is going to be based on that 2,000 patient study, and there's no and nobody probably has any questions about what the answer is going to be at that point, if you have kind of that done. So that's the other thing, is to make sure that you have one that's both clinically valuable, but also hasn't been answered already via some other kind of methodology.
Yeah, no, that's a very good point to think about the quality of evidence going into it. I want to, before we go into the quality of the evidence, which I do want to talk about a little bit for sure, because that's a huge component of systematic reviews. Dr. Harrison, you mentioned registering your protocol and having a very discrete protocol. And it sounds like that comes way earlier than anything else and really is used to really define all these things that we're talking about. Can you talk me through that process? Where do you register it? Kind of what that looks like for real for these, because it's not a clinicaltrial.gov.
Yeah. So at first I would say that the reason why I single out the protocol, in regards to the last question, is the way I look at it is, once you have finalized your protocol and you have done your search that you are then going to go through, like you've done the search, not including any piloted searches to revise your protocol, that's kind of the point of no return. And not that there's no return, but that if you get to the end and you realize past that point that you need to start over, it is completely starting over. So, to the specific question of what that looks like, it depends on what you're doing for the systematic review, who you're writing it for. If you are writing an unsolicited, just general systematic review that you're saying, we're going to publish in a journal, and there's a handful of journals we'll look at. There's different registration bodies out there, but Prospero is, the big one, the one that everyone talks about. There's some more specific things, especially if you get into things like, more specialized topics. The other big one, though, that I would say is to realize that the Cochrane collaboration, who obviously does a lot of systematic reviews, they do their own sort of process where the protocol is actually its own publication separate. So that goes through peer review. You have a certain number of months, I can't remember how many months it is, after you have to register the title, get that approved. Then you have a certain number of months to write and finalize the protocol. That gets peer reviewed and then potentially approved. And then you go on and you write the actual systematic review. So it does depend on who you're doing it with. But if the general answer, I think, for if you're doing it unsolicited, Prospero is a good bet. And it's a very searchable database that allows you to go see, did somebody already do this? So, which I think is as important as anything else, right?
Dr. Lee or Davis, do you guys have other databases that you really like to use, or does pretty much everybody stick with Prospero?
I'm pretty sure most people do Prospero, but the other benefit to registering, in addition to like making you stick to your guns and making it reproducible, is you kind of have marked your territory that you're already in process of it. So the worst thing that like the biggest nightmare that you have is you're in the middle of doing a systematic review, you're like writing up the publication, and then somebody else publishes on like a very similar, the same topic, and then it's going to be nearly impossible to get yours kind of published after that comes out. So you can kind of mark your territory once you kind of have had it registered there. So hopefully, everybody kind of checks those databases before they, and people are doing best practice, they kind of do that. I will say one of the things that we keep bringing up is like you get to the end and you don't have articles or you have to change your search topic. There have been publications out there of that don't have any results or have one study in them, basically with like the content of, you're not going to get, a headline, annals publication from doing that, but you can probably find a place to put some of those if, again, it was an important question and it's something that's a clinical practice and we don't have any evidence for it. Sometimes the publication of there is no evidence for doing this is actually a valuable thing to write sometimes. So it's not the end of the world to, get to the end and not have something done. Sometimes that can be valuable. And then for those people who don't know, Cochrane is like it's out of the UK and they're considered like the gold standard for like best practice for doing systematic reviews and meta-analyses. They have lots of resources for how to do them. They have kind of their ideal world and they have a huge team that's funded and stuff to kind of do this. Ideally, you would do everything that they kind of have in their kind of guidelines and stuff. Not everything can get done on every like small body kind of systematic review, but both that and then PRISMA, which are the guidelines written, the preferred like reporting for systematic reviews and meta-analyses. Those are probably the two best resources for people to start with if they wanted to weren't familiar with this. Those are probably the best to look at. In addition to, like I said, Prospero, I think is what most people register.
Yeah, Dr. Harrison, I saw you raise your hand.
Yeah, sorry. I just wanted, before we passed over it, to hit on what Josh just said. I would even go one step further about the negative systematic review. I think realistically, from a scientific perspective, a negative systematic review is actually very useful. We all live in the real world, and unfortunately, there is such a thing as publication bias, or publication of negative results. Ironic, that we're talking about systematic reviews, since that's an important part about the systematic reviews. But so I think the real consideration that you have to make is, what am I going to do personally? Is this something that I can commit my time to if it comes back negative? But from a purely scientific perspective, I actually think that the negative systematic review is kind of awesome, because it gets at something that we were all saying earlier, Josh really harped on it, is that if there's something for which there is no evidence, then you have just done the study to show everyone that they can look at and say, yeah, there's no evidence for this. We need to do more research. And as someone who does a lot of clinical research, that is the kind of thing that is incredibly important for getting funding for new research to be done, is showing that there's a gap.
Yeah, Dr. Lee.
Sorry, I can't find my raise hand gesture here.
Yeah.
But I like to echo the both of my colleagues' input there. The negative study is important, especially someone who's seeking the future grant. I think it is important to generate some type of what's called a preliminary data. And in this case, the negative review, the negative results means that there's more need for more study. And that would be a strong argument to push forward with your own specific aims. So if you actually have this relatively healthy cycle of publishing work, collecting preliminary data using a systematic review, I think that would actually keep you very productive. One of the things I actually wanted to mention about this is more towards the dark side, but once you actually publish your study protocol, that is actually visible to anyone. So in some instance, someone else actually wants to study the same question. So it is actually something that other people can actually look up to. So it actually can have some negative effect. So I have tried to be a little bit careful about the timing of submitting a Prospero for the study protocol. I want to actually make sure that we have a decent study protocol and we have everything ready to pull articles for selection. Because if we actually publish that protocol and wait for good 18 months, someone else is going to do that study. So I think you want to be careful about the timing of submitting that Prospero.
Yeah, that's a good point. It can go both ways.
Well, and the other thing, I mean, it's kind of like a patent, right? Like once you put it out there, then everybody, Coke's never been patented because nobody has the recipe because they don't want to give it to anyone and kind of give it up or whatever. But the other thing about Prospero too is you have to, it's published and it's publicly viewable, just like a clinical trial registration. So like once you want to have some preliminary work done, like Dr. Lee was saying, so that like, because you don't want to change your outcomes after you've already published what your protocol is, because that can add a little bit of kind of bias and stuff to the study. So you want to have done a lot of the preliminary work, some of the preliminary searches, run your question through a whole bunch of times. You don't want to be publishing your Prospero when you're still like updating your question, or again, that you don't want to do that when you're halfway through the study and then decide that you need a different outcome or something like that.
Yeah, good point. When you start, so by the time you have a protocol, I'm curious where you start engaging the librarian and a biostatistician in this process. Like how early, how do you choose it? How do you find this person? Because not everybody just knows a librarian who can do this specific type of research for you.
Yeah. So, I mean, as early as possible. They're going to be the ones helping design it. They're going to be able to clarify for you. They're going to be able to do those preliminary searches and tell you like, hey, if we phrase the question like this, I'm going to hand you 40,000 articles to 40,000 titles to review. And so you might want to make it a little bit more specific, or maybe they don't understand like exactly what you're asking, and you can help clarify that for them. But particularly for that, and then again, for the kind of statistician, you want to get them on board so that as soon as you are getting your question and your outcomes, that you're collecting the data in a manner that they can analyze it appropriately if you are doing a meta-analysis. Now, again, not everything is applicable to a meta-analysis, and trying to squeeze things into a meta-analysis that are not good is like one of the biggest problems with like systematic reviews and meta-analyses is like garbage in, garbage out kind of like type thing. And so making sure that you have like adequate studies and you have a statistician who's going to tell you like, no, I'm not doing that. Like that's scientifically invalid and I'm not doing it. Because you can, right? You can put all of the things into statistics and come up with a point estimate or numbers and stuff, which looks really nice. Like people really like to have that, but sometimes that's just completely invalid, even though you kind of came up with it. And so having them on board early so that you can design the question appropriately, but then also collect the data in a manner that is going to be available for them to do the kind of statistics appropriately.
Yeah, good point.
Yeah, I would just add to that the Cochrane process is they will assign those people to you. Now, they will fully expect, because they are the Cochrane collaboration, that you have put an very, very detailed plan for how you're going to handle certain biostatistical questions like heterogeneity and what you're going to define as heterogeneity, which is, we can get into that later, but essentially the idea of when is it okay to combine these studies that might be slightly different, and if we do we have to use a different analysis technique? So I will put a plug out there for Cochrane that like they will help find a biostatistician and a librarian for you so that even before you are finishing your protocol that's all done. Otherwise it's hard. A lot of, if you're associated with a medical school, I think most medical schools have medical librarians who can do this, but the question is, how many are there? How much bandwidth do they have? And then certainly if you're not directly, depending on, there's lots of forms of academic medicine, right? And so like how closely you are associated with a particular medical school can make that access harder. And I don't have a great answer to that. I don't know if any of my colleagues do.
Dr. Lee, any other thoughts on the librarian or biostatistician and kind of their role when you get them involved?
Sure. So I think I mentioned about how important it is to involve a librarian. I think in order for us to submit and get the article accepted to the peer review journal, having a librarian who can generate the search strategy is actually crucial. And if you have access to grant, you can offer grant. Oftentimes that's not the case because we are at the stage to gather some data and generate preliminary data. So in that case, you can always offer academic credit. So in that case, it will be actually sharing authorship. Librarian will be actually given the co-authorship because the person actually contributed to the systematic review. So that's my take. In terms of the biostatistician, I think it really depends on your question and the type of data you have. I think that most of us actually, if we have done a few systematic reviews and the meta-analysis in the past, we received some type of a basic training on how to use a software to do a meta-analysis. So it doesn't actually take a lot of a time or effort to do basic meta-analysis. It can be time consuming when you actually get into the specific analysis, such as meta-regression. Another one is a network meta-analysis. And then the last one is actually the patient level meta-analysis. So if you actually come across those critical points, the critical issues, I think that will be reasonable time to involve a biostat person. But this may be my own preference. Others may actually have a different approach for the when to involve a biostat person.
Yeah, I completely agree. I mean, the basic combining studies when it's diagnostic studies and interventional studies, because the other category, prognostic studies, there is some trickier aspects to that, but combining your diagnostic and interventional studies together most of the time is actually like pretty easy from a biostats perspective. But you're right, like I think it's good to draw that delineation there, that when you start getting into more, especially meta-regression, that's something where you probably want someone who's experienced to be able to do that.
I would say like when you're getting started, like doing your first systematic review is not the time to like try and write your own search strategy and run your own like meta-analysis, right? Like you want to have someone and have done a couple, and like Dr. Lee was saying, once you've done a couple and you've been through it, you've been through some of the pitfalls, you understand some of the bumps along the way, how to use the software, you've had someone kind of show you and or like done some specialized training in it, like that's really when that's the key thing. Like for example, like I mean, I don't really have, I'm a Excel community, and like so I don't have access to like this anymore. I used to, but I don't have access to biostatistics to librarians. Like I write my own sort of my search strategies. I do my own meta-analysis at this point, but that's because I've done it a whole bunch and I like understand how to do it, and I understand like what the pros and pitfalls and what the I can write my own stuff after having done it. When you're first doing it, that's not like the time to do it. And I know this is like really easy to say, and not everyone has like access to these resources, but particularly for the librarians, somebody who is an expert in doing systematic reviews and meta-analysis is really going to be like somebody who's done them before and understands how to do them is going to be a much better valuable resource to you than just like the like person sitting at the desk when you walk into like the library at your hospital or whatever. Like finding someone who's really done this and understands it, particularly when you're just starting, is going to be very helpful, because again, there's a lot of pearls and pitfalls, and even like somebody who's trained in like has a master's in library science or whatever, like this still may not be their area of kind of expertise, and there's a lot of niche things that go along with doing a good systematic review search.
Yeah. So I want to kind of shift gear, because one of the big things that has come up is kind of the quality of data. And as I think it was Dr. Davis who said it, garbage in, garbage out kind of perspective. What tools have you guys used to assess bias? What are some tips on how you kind of figure out, is this good data to be including in the meta-analysis, or should I be refining the search before? Again, I'll let Dr. Davis take it away, since it was your kind of initial input.
Yeah, I mean, that's really a tough question, because it's very easy to get very excited about a topic and to put a lot of effort in, and then like you just want to keep going because you kind of have the momentum and stuff. And I think one of the big tools, like Dr. Harrison mentioned, is looking for heterogeneity and making sure that you're, like I said early on, like you've designed a question that has very specific populations and outcomes, but also that like your intervention is somewhat similar. And so like the further you get away from that, the more that you're like I said, you can put all of the things into like, you have to actually read the studies and make sure that they're studying the same thing with a similar intervention that you think is close enough that it's going to be like it's worth combining them. You can take all of the numbers and put them in and get a number, like spit it out of a statistical software, but it's not going to be a valid number if you're doing very heterogeneous studies looking at very different populations or different interventions. Or if you are going to do that, then determining what subgroups you're going to look at in different kind of ways and stuff. So one study that I had done previously was looking at like the accuracy of like ultrasound for diagnosing either foreign bodies or appendicitis, and right. But then I had decided like, I'm going to do emergency medicine point of care ultrasound. I'm going to do other specialty point of care ultrasound. I'm going to do radiology ultrasound, and that was I can give you an point estimate of what ultrasound is, but because of how operator dependent it is, I felt it was important to like separate them out, because the diagnostic accuracy is actually slightly different when it's done by an ultrasound tech in radiology than a point of care ultrasound. It's not quite as good when you do it kind of with a point of care ultrasound, but I think that that's an important designation. Even though, like I said, I can put them all in and give you a point estimate too of what ultrasound is, that doesn't really give you the the clinical applicability. And that really depends on the topic that you're studying. And kind of like I said, that's why it's important to have a content expert and to kind of understand it to begin with, because there's a lot of those things, and you may not, if you're not an expert or you don't, you may think you understand it all, but you may not be thinking about some of those things from the beginning. And you may find it afterwards. Like after you're done, you may find that you have a lot of heterogeneity. And that means, like, if you find a lot of heterogeneity, that means you need to think deeper about what is different in the studies that's causing that.
Dr. Lee, do you have a specific kind of tools that you use to help with identifying heterogeneity or bias in your studies?
Sure. So those are actually a couple of questions that I can actually cover here. So in terms of the risk of a bias tools, it's probably the safest to refer to the Cochrane website, because that actually site has several tools that are available for us to do. And it's actually, revised every here and there. So it's a good idea to go back and do a little bit of research and see what's available. For the randomized clinical trials, I think the Cochrane risk of bias is considered the reference tool for the risk of bias. I don't think many people would actually make an argument for that. And it's actually very intuitive. It has a very good instruction manual and the flow chart that would actually walk you through how to do a risk of bias. If it's a non-randomized clinical trial, but it's including some kind of intervention, then there is another tool called the Robbins, and that is a little bit more cumbersome than Cochrane risk of bias, but that's what I actually have used before. For the diagnostic studies, I'm sure that my colleagues here actually would explain this better, but there's a tool called that's actually used for the diagnostic studies. And say, your research question and the research design from that selected articles are kind of all over the place, but it can actually fit into the category of observational studies. You can rely on a tool called the Newcastle-Ottawa scale. All of these tools are, a fair game, and it will be enough to convince reviewers and editors. Some of them actually are not the best fit for your research question. So it's actually totally reasonable to make some modification and make it a perfect fit for your own study.
Yeah, Dr. Harrison.
Oh, sorry. Yeah, I think you absolutely need to pick something. You need to have a formalized. That said, like Dr. Lee said, if there is something about your question or your population where the particular tool, there's an aspect of it that doesn't fit, I think as long as you can very clearly and soberly explain and justify why you made a modification, that's acceptable. I mean, it's like anything else, right? Like any research, you just have to be able to justify the method. Like if you do a method that's not been used before, you have to be able to justify it and justify it in a way that peer reviewers are going to buy it. I also I think that it's good to make a bit of a delineation, just because we've been talking about them together here, but there is risk of bias is one aspect, and then assessing for heterogeneity is its own separate issue. And that, unfortunately, is much harder. It used to be, so there used to be some kind of global statistics that we would use. The most common was the I-squared test. That has in recent years, I don't want to say fallen out of favor, because it's still used, it's still important, but it used to be more acceptable to say, well, if you have an I-squared that's less than 60, then, then it's fine. And if it's more, then it's not fine. And Cochrane in particular, and I think, the General Systematic Review Committee has kind of come out more and said, well, now you need a more individualized approach. No one, to my knowledge, and maybe you guys know of something more, I don't know of anything that was quite as simple as simply saying, we're going to pick a cutoff for, the I-squared or whatever. I don't think right now we're at a place where that is. So it really is a challenging thing to decide. It takes a lot of soul searching and knowing the literature.
So, if there isn't a kind of perfect tool for heterogeneity, so it sounds like bias, they're very well established. This is the one you can use for this type of study. You may adapt it a little bit, but pretty well established guidelines of how to do that. So if there isn't a tool for heterogeneity, what are you left kind of doing then, I guess?
Great question. You're reading that chapter in the Cochrane Handbook and going through all the different things. And then I think, what may or may not be a healthy metaphor or analogy rather to think about is it's not that there aren't summary statistics that are useful. It's that like you can think about it like a p-value or even a confidence interval. These things have limitations. They are statistics that you always trade off like having one summary statistic for having applicability to all problems, right? Like there's an inherent balancing act you have to do there. And so it's more that you just have to recognize that there are limitations to the statistical tools that we do have. And then, like I said, read the Cochrane Handbook, the most recent version on this, because they go into probably more depth in all of the tools you can use and all the reasons why those tools may or may not be useful, just like, your p-value.
Just maybe add, one thing there, going back to the original question about kind of bias. And so there's two kinds of bias that we assess. There's the study within study bias, or the study, and those were all the tools that Dr. Lee said. And honestly, I think Dr. Lee, those are all of the common tools that are most well accepted. He named all of them. And so those, if you're just starting, those are the ones you kind of want to use. And then there's, between study bias. So kind of bias between the studies, and heterogeneity is one form of that. But one of the other things is publication bias, like we had talked about before. We had talked about it in a different context, but so a funnel plot is typically, again, not the most perfect thing in the world, but it's typically what we use to assess for publication bias. And that can kind of show, if kind of larger studies have more positive results, are more likely to be published, and kind of the smaller studies with larger confidence intervals may not have been. And so that can help kind of direct that as well. And so that's just another kind of important aspect. And like I said, using the tools Dr. Lee mentioned is probably important. One of the pitfalls that I have seen done previously by kind of novices is to try and use a tool that's designed for like assessing quality of a study, or assessing like how well a study is reported. So like the consort for a randomized trial, like that is not a risk of bias tool. That is a like quality of reporting tool. Or Prisma for like a systematic review, right? Like that is not a risk of bias tool. That is a quality of reporting of systematic reviews. So if you're gonna do a systematic review of systematic reviews, like be super meta about the meta-analysis. That is like, you wanna make sure that you use a tool that's designed to be a risk of bias tool, and not just a quality of reporting or quality of study tool.
Grade is the same. I think that often that's a common one where people think that you can use grade as a risk of bias tool, but even grade, the powers that be behind grade say no, you should be using an independent risk of bias tool.
I think those are all really good points. As we're slowly wrapping things up, I wanted to touch on something. So you guys also mentioned that there are alternatives to like a full meta-analysis. So I'm curious if there are specific like better like forms of review that are suited for certain topics versus another. So I know there's like scoping reviews out there. There's the systematic review without a meta-analysis, with the meta-analysis. I'm kind of curious if one of you guys want us to start and tackle what are the other alternative forms for quality reviews.
So some of the other forms are kind of the scoping review, the narrative review, and those are kind of the reason that we stick to systematic reviews is because of the protocol and the reproducible nature. It actually makes it like a research study. Whereas if I'm writing a scoping review or a narrative review, there are some guidelines for reporting them, but it's at a much higher risk of kind of putting my own biases in there. So if I think whatever intervention works and stuff, I can cherry pick the studies that show that. And you've probably seen that in some of these things like recently about COVID that have been published. Like you can cherry pick certain sentences from certain studies and put a your own blog out there about whatever like COVID intervention that you think does or doesn't work. And it may not be representative of like the totality of the evidence kind of reviewed by the experts and stuff. And so those are some of the like kind of other ones. The scoping review is typically designed in more of it does still have a question. It just is, and like a search protocol is just not as standardized. The narrative review, or kind of the just the typical review article that you would write, that's typically just topic based, doesn't always have like a specific question. And again, that is just someone who's an expert like writing up about a topic and writing whatever their like opinions and practice are on it. I mean, it's all based, they are an expert and it is, supposedly based in their expertise, but it may have some bias from the kind of scientific evidence standpoint and be biased towards kind of like the expert opinion, clinical experience kind of type thing. And you won't have any way of knowing that when you read the paper that that's what it is, other than understanding that that's that's what those kind of are at risk of. I actually really like writing systematic reviews without meta-analyses sometimes. I think those are so you had mentioned, some of the stuff I've written on is like handoffs and stuff. And that's a lot of like nursing research and qualitative stuff. And so it's actually really like fun and interesting to try and put those into like, categories and stuff. And it's difficult. It's much more difficult than, like I said, putting all the numbers into a machine and spitting out a number and just writing a statistic with like 95% confidence intervals. That's very easy to do. But sometimes the evidence doesn't support that. And sometimes that's not like, doesn't give you all the nuance that you really need. And then you can get into like really detailed subgroup things and stuff like that. So that's actually really fun too. So you don't always, like I said, don't always be hindered that you have to do a meta-analysis on something, particularly if you have a topic that's a little bit more, nebulous or qualitative, or may not have multiple studies that are super homogeneous and that are answering the same outcome. You may have several related topics, but several related studies that have minor differences in the interventions, and really meta-analyzing that's probably not a good idea. Actually, just looking at the different studies and how they differed might actually be better.
Yeah, you were shaking your head in agreement with a lot of that. I'm curious what your thoughts are in terms of personal bias when you're writing these narrative reviews, or how do you get around it, or other types of, somewhat systematic reviews, but if they're not a true systematic review.
Sure. So I have seen a few different pathways in the past, so I can actually talk about my own story or the scene. So if you actually happen to be the expert in that field, so whether it's like a sepsis, RLS, CHF, and ultrasound, or whatever you actually specialize, and you are the expert, I think the narrative review is still going to be useful, and you can actually find a peer review journal that would actually take you up on it because of your name. So that's a one way to write a narrative review. And unfortunately, I'm not one of them, so I have to rely on a different research methods. So what I do is to supplement my deficiency with a research methods, which is actually the systematic review plus minus meta-analysis. If I come across the research question that has a couple of studies that actually using a similar exposure and outcome, then I think that would be great. I can actually plan to do a meta-analysis. There's some question about whether the pooled analysis would be too heterogeneous or not. That's actually an issue that we can actually deal with later. If I know that the research question is good, but the study results are actually all over the place, I don't think I would actually hold on to that idea of a meta-analysis too much. So that would be actually systematic review without a meta-analysis. It still gives me a pretty decent spot to aim at the reasonable peer review journal. So when do I actually get to write a scoping review? I have actually written a few related to the conference, and that well, I use a scoping review when I actually don't know what's out there. So first of all, we do a search. It still is a novel topic, and we can actually publish something out of it. That is when I actually try to choose the scoping review. So I don't do the risk of bias or meta-analysis. I try my best to synthesize what I actually got, but it tends to be a fairly large number of articles. So I would say that that's probably when I actually would use a scoping review. So that's my take.
That's wonderful. Nicholas, Dr. Harrison, any other last thoughts on this?
Yeah, I think I might give a semi-insane answer to this, but actually, when I've written, invited reviews in the past, I think a good practice, although one that makes it a lot harder on yourself, is to incorporate as many systematic review components to the methodology into the search as possible. I mean, that you still can't call it then a systematic review, but I think it's very helpful to me for some of those narrative reviews to, have an independent search strategy, a clear question, work with a medical librarian to do it. And then even there's a narrative review that we were invited to write that we're working on right now, where we went through too many articles, but we went through them, just at the title and abstract stage, and then we did a full text review, and we didn't go so far as to do risk of bias on all of them and all that. So it's still not a full systematic review. But I think incorporating as many of those practices as possible is helpful, because ultimately, like, those are the best methods. Like, that is the methodological standard for rigor in this kind of thing.
Well, with that, I think we're kind of out of time. I really want to thank all of you for coming and having a great discussion. I think this was really informative, and I have to say, I wish I had done it before I had tried to do a systematic review. I think my life would have been a whole lot easier. But thank you all very much for coming, and I look forward to working with you guys in the future.
Yeah, thanks so much.
Thanks so much.
And feel free to reach out if you have any questions. I think I'll speak for myself, but I think everyone else here would be open to having anyone reach out to us individually. If you have any questions or want some mentorship or help in a topic, if you're new to this, I think we'd all be happy to direct you, even if it's not our topic of interest.
Yeah, absolutely.
Thanks.
Thank you all.